Hi, my name is Kennedy Johnson, and this past summer I've worked in the lab of Dr. Harvey Coxon under the supervision of Miranda Kirby at St. Paul's Hospital in Vancouver, British Columbia on a project called the Presence and Progression of Emphysema in HIV-infected individuals. So human immunodeficiency virus, or HIV, is a virus that causes suppression of the immune system. It lessens the body's ability to protect itself from pathogens. HIV severity can be determined in both its CD4 count and its viral load. Improvement in treatment has increased the longevity of HIV-infected individuals. However, with an increase in lifespan comes an increase in concern for age-related conditions like emphysema. A previous study done at St. Paul's, where I worked, has shown that subjects who are positive for HIV have an increased risk of cellular aging. Therefore, HIV-positive individuals may have an increased risk in developing chronic obstructive pulmonary disease, or COPD, which was of particular interest of my lab. One characteristic of chronic obstructive pulmonary disease is emphysema. Emphysema is defined as the presence of permanent enlargement of the air spaces distal to the terminal bronchioles, accompanied by destruction of their walls and without obvious fibrosis. This picture shows a segment of frozen lung where the inside arrow points to airways that have become enlarged from emphysema, while the outside arrows point to an area of the lung that has remained relatively preserved. The histological sample below shows a control side and an emphysema side. The control side shows small airways and the surrounding walls have remained intact, whereas the emphysema side has much larger airways and the surrounding walls have become damaged. Histology, like the picture I just showed, is currently the gold standard in quantitative analysis of emphysema. However, it is invasive, sampling is limited, and it cannot be repeated. Alternatively, computed tomography or CT scans have provided imaging of the lung that is non-invasive, cost-effective, and can be repeated, which is the technique I used during the summer. CT scans are created using X-rays that produce cross-sectional images of the body. The X-rays pass through the body, and dense tissue, like the blood vessels and the bone, show white because they absorb lots of X-rays. The area here is the lung tissue, which shows up gray because it absorbs a medium amount of X-rays. And the black area here is airways, and they absorb no X-rays at all. Emphysema is measured using a value called the Hounsfield unit, and it is a relative scale that puts the Hounsfield unit of air at -1,000 and the Hounsfield unit of water at 0. Emphysema is characterized by lung tissue having a Hounsfield unit of -950 or below. This first picture shows a lung that is very severely affected by emphysema, and all of these yellow areas are areas of low attenuation, which means areas that record a Hounsfield unit of -950 or lower. So from the graph, you can see that at -950, more than 10% of the CT voxels are recording that number. So that means that the emphysema is very severe. On the other hand, this picture depicts a much healthier lung, where close to 0% of the CT voxels are recording a Hounsfield unit less than -950. So the hypothesis of my experiment was, do HIV subjects have greater and faster progression of emphysema compared to HIV unaffected subjects with equivalent smoking habits? The specific aims of my research include, number one, measure emphysema using CT scans of HIV-positive individuals. 2, to compare the extent of emphysema between HIV-affected and HIV-unaffected subjects. And 3, measure the progression of emphysema in HIV-affected and non-affected subjects. Aim number 1 was the specific aim of my summer. So baseline visit 1 CT scans were imported into a program called Apollo, which first reads the CT scans and recognizes all the airways. So this colored area here are airways. Next, it segments each lobe based on the fissures that you can see on the CT scan. So this would be the right lower lobe, right middle lobe, right upper lobe, left upper lobe, and left lower lobe. It then creates a 3D image of the lung, and these areas are each color-coded based on which lobe they are in. And all the little dots represent low attenuation areas, or areas of emphysema. And the larger the dots, the more severe the emphysema is. So from this picture, we can see that this individual has very severe emphysema in the right and left upper lobes. Here is a table including both my results and my demographics. I had a total population of 102 subjects. All of them were 18 years or older and HIV positive. We had 54 current smokers, 32 former smokers, and 16 never smokers. The average age ranged from 50 to 53, which is fairly young for a COPD cohort, and the average sex was male. I've also included our results for FEV1 and FVC. FEV1 means forced expiratory volume, which is the amount of air one can expel from their lungs, and FVC is the total amount of air they can hold in their lungs. We can see that the never smokers had the highest percentages of FEV1 and FVC, but the differences between each group is very insignificant. Here are the results for our Vita Diagnostics, which is the program that runs the data from Apollo. We looked at the total volume, total air volume, and lung mass for each group. And there are trends, but again, the differences between each group is insignificant, and this is the same when we looked at the average low attenuation values. Here's a graph depicting our average low attenuation values in FEV1. COPD is characterized by having less than 10% low attenuation values. So most of our population is unaffected by COPD. However, there are a couple individuals that have very severe COPD, and this means that they would be interesting subjects to look at in a longitudinal study. We also decided to look at the HIV and low attenuation value relationship. So if the individual had a detectable versus an undetectable load, and if they had a CD4 count above 350 and below 350, while it does seem that those who have more immune suppression also have more emphysema, the difference between each group is insignificant. This is the same when we plotted the graph, but it does show that these individuals have very severe emphysema and very high immune suppression, which means that those individuals are also very interesting to look at in a longitudinal study. In conclusion, quantitative emphysema measurements overall do not appear very severe in HIV-affected individuals, and this could be because our entire cohort was relatively young. There does appear to be a subgroup of individuals with severe emphysema, however. There was no significant difference in emphysema between high and low viral load and high and low CD4 counts. And lastly, smoking and immunosuppression may not completely explain the risk for COPD. For future directions, we would like to determine how emphysema progresses over time. So we would look at CT scans that were taken 3 years after the baseline CT scans. We would also like to compare an HIV non-affected cohort. And lastly, analyze small airway measurements to better characterize COPD in HIV. I'd like to thank Dr. Harvey Coxon and Dr. Miranda Kirby for supervising me, and Dr. Donson and SS Paulman for funding this project. Thank you.